أول سلايد management of ischemic heart disease التوبيك حقنا اليوم. ممتاز، بارك الله فيك. طيب، معكم الدكتور خالد الجهني، استشاري قسطرة وقلب جامعي. اليوم حديكم محاضرتين، محاضرة عن ischemic heart disease والمحاضرة الثانية عن valvular heart disease the common. It's not ideal through Zoom, بس احنا we're trying to accommodate the situation we have. I hope everybody is safe and sound. إذا في أي سؤال تقدروا تكتبوه في الشات، ممكن نخليه في النهاية أو نقدر already we proceed. Okay. يلا بسم الله. طبعا الأوبجيكتيف حقت اليوم إنه I want you to understand coronary artery disease لأنه it's an evolving concept now. In the old days احنا كنا نسمي coronary artery disease acute اللي هو ال ACS and then the stable angina patients. But now there was a change mostly in the European guidelines to the names of this. I don't think you need to know it for the exam purposes. It will be the same to us, but it's just good to know that coronary artery disease now become acute coronary syndrome and chronic coronary syndrome in some of the part of the world, Europe. يعني حتى لما تقروا في الجايدلاينز الجديدة اللي طلعت عام 2019 you will see that they use this reference acute coronary syndrome اللي تحتها STEMI, non-STEMI والunstable angina. In the old days كنا نسميها stable, they call it chronic coronary syndrome. طبعا نشوف as we mentioned, that's the objective. You'll see some of the pathways and strategies and algorithms to how to manage these diseases. هذه هي guidelines. If you have time, read it. It's very informative that they change the concept of the whole concept of coronary artery disease into acute and chronic. That's exactly, just for your knowledge, exactly what we mentioned. What do we call a chronic, and how do you call the coronary artery disease? And as you can see here, يعني هذا الدياجرام it will show you the difference that any patient who started with coronary artery disease, acute, will convert himself automatically into a chronic status after stabilization or achieving the treatment in the chronic phase. دقيقة بالله، بس المشرفة بترسل لي عليكم في الويتنج روم. طيب في أحد في الويتنج روم، كيف نخرجكم؟ طيب participants admit all. معليش يا شباب technical difficulty. طيب ممتاز. يلا نرجع لما ذكرنا. أول شيء الشباب اللي دخلوا حياكم الله، معكم دكتور خالد. بس احنا we were discussing the concept of stable coronary artery disease. the new formology اللي دحين شغالين عليه it's called acute and chronic coronary syndrome. In the old days كان عندنا acute coronary syndrome اللي هو STEMI, non-STEMI and unstable angina, and then we have the stable patient where they were labeled stable angina patient. The name has changed, especially in the guidelines So you have to be aware that now when you read something called chronic coronary syndrome, it is something new, and I think will be adapted by all the society in the coming future. طيب. And I always tell the patient that comes to me, لأنه the population that can come to you in the clinic are divided into two. Again, it's acute and chronic. The acute اسمها جلطة قلبية or acute coronary syndrome, where the patient has a plaque, not necessarily stenosis زي ما في الصورة تحت أسفل الصورة. It's just a plaque that ruptured and then occluded the vessel completely in STEMI or incompletely in non-STEMI or unstable angina. That's a spectrum of acute coronary syndrome. هذه في العادة ما يجوك في العيادة. They come to you in clinic, in emergency room. أو walk in clinic إذا ما قدر يروح للإمرجنسي. So they come to you complaining of a new onset chest pain with its associated chest ECG and enzymatic elevation. The other spectrum of group, which is اللي هو الذبحة الصدرية in Arabic، ما هو الجلطة القلبية، الذبحة الصدرية، وهي اللي تنتج عن occlusion of the coronary artery, limiting the flow, which at some point will make the flow to the myocardium low, that it become ischemic, especially with exertion. It will never happen at rest because it's not an MI. If it happened at rest, خلاص, the patients move from being a chronic into acute. And the process of atherosclerosis starts at birth. When you're born as a human, because we are exposed to environmental factors, our genetic factors, smoking, eating fatty acids, it will accelerate the process. لو انتم متخيلين هذه الصورة سهم from above to down, as you can see here, the rate of acceleration depends on many factors. Genetic plays a major role. Being a male will play a major role, because أنا لو سويت دحين CT scan أو تشريح للهارت حق كل الطلبة اللي في الليكتشر الآن, most of us will have, none of us will have 0%. Most of us will have a stenosis, but it is 1%, 2%, 3%. I think the maximum will be 20% at the age group and my age, يعني أنا 36. With this age group, we rarely have, unless you did bad in your life, you smoked heavily, you're not exercising regularly, you're eating Big Mac every day. That will make the acceleration, توجهك للسهم يطلع فوق. But then the stenosis, when it reach a level labeled as 75 في coronary arteries, regular coronary. سامعين يا شباب؟ Hello? لا هذه كانت مقاطعة. طيب. When the rate ما قدروا يدخلوا, لا دخلوا يا شباب. أنا لغيت غرفة الويتنج روم. عاد تحملونا يا شباب, هذا الزوم and its problem.
أو ما عندي.
ما في أحد في الويتنج روم, صح يا شباب؟ جاهزين؟ ممثل الجروب يقدر يتكلم. Disable and notate. أبشر. Disabled already. خلاص شباب واضحة؟ نكمل؟ لو واحد بس من ممثل الجروب يتكلم أو ترفعوا تكتبوا لي في الشات. حاولت والله ما راحت الديسيبل نوتيت. ممكن أحاول أسوي لها كلير. لا. كلير أو درونج. خلاص يلا. يلا بسم الله. فزي ما ذكرت لكم going back, الريت changes based on what you do in your life. Once the stenosis happens at a certain degree, المتعارف عليها 75% in the normal coronary artery, the flow will be limited by 90%. Thus, it will induce ischemia. Unless it's a left main, which is the exception is 50% instead of 75%. عشان كده احنا we intervene in these patients when they reach the 75% in the normal other coronaries, and 50% if it's in the left main. This is the spectrum. The rate, as you understand, starts from age, but the rate of progression depends on you and your factors. Then you're male, you can't change that. If you have family history, you can't change that. There is some genetic treatment, but it's still experimental. The only thing you can do if you have genetic problem, that you know you're a heterozygous or homozygous hyperlipidemia, you know that you're at high risk, so maybe you'll take treatment initially. And that's why we screen these families. And even at their young age, they will start taking Cristal, an anti-lipid medication. طبعا this is البالانس اللي احنا نسعى فيه في my management. يعني أنا البيشنت اللي أشوفهم في العيادة، البيشنت اللي أسوي لهم coronary angiogram and fix their artery, I'm trying to achieve this balance. البالانس دائما between the oxygen demand and the oxygen supply. لما a patient comes to you with angina, you aim to decrease the demand. How do you decrease it? By decreasing heart rate. عشان كده نعطي beta blockers. You decrease the wall stress. How do you decrease the wall stress? By decreasing the preload and afterload. If the patient is hypertensive, his blood pressure at 180, you reduce it to normal blood pressure, it will reduce the angina, reduce the demand. The contractility. If the patient have thick myocardium and contracting forcefully, slowing down the heart, reducing the ionotropic effect of the myocyte can help reduce the angina. And the other way, and then an oxygen supply. So if you exhausted your treatment in oxygen demand by minimizing the heart rate, managing the hypertension, and reducing the contractility power, then you have the other option, which is increase oxygen supply. How do you increase oxygen supply? If the patient is anemic, هذا rarely من تحت هنبدأ لفوق, you can give if I put you in a hypoxic state, at some point you will have chest pain because the oxygen going to the heart will reduce, and then you'll have, it's not a blockage, it's not a thrombus that formed, but it's a hypoxemia that led into ischemia. Patent coronary artery هذا شغلي. As an interventional cardiologist, I open up blocked vessels. So all what I do in my practice is just playing in one factor, which is opening a blocked artery to make a patent coronary, i.e. to make a better flow to the myocyte, i.e. increasing the oxygen supply, reducing the angina. Or نخلي الميزان يصير متعادل فيصير المريض have less angina. There is something called coronary perfusion pressure. It's not important for you to know, but if you understand the hemodynamics, you would appreciate this equation. So the coronary perfusion pressure, it's the diastolic blood pressure minus the LVEDP. So if the patient comes to you in a shock situation, his LVEDP is sky high. The normal is 20 or less than 20, and he's coming with you in shock, and the LVEDP, which is the filling pressure, left ventricular end diastolic pressure, it's the pressure inside the ventricle at end diastole. And he's ischemic. حتى لو فتحت الvessel, he will remain ischemic. So what you do, you try to manage this high LVEDP by diuresing the patient. So you reduce the LVEDP to normal. وهذه equation. So لما تنزل LVEDP, perfusion pressure goes up. When you increase the diastolic pressure, you increase the perfusion pressure. So the same way around, if the patient جاي بacute AI, where there is a ruptured aortic valve or leaky aortic valve, the diastolic pressure will go down. The only way to increase the perfusion pressure is by fixing the valve or making an afterload reduction to increase the diastolic blood pressure. The aim, it might be too complex, but the aim is you want to increase the diastolic blood pressure. So when you increase the diastolic blood pressure, the coronary perfusion pressure gets better, and then the angina resolves. This is the same thing that I've told you, the cascade of ischemia that happens when there is an increased stress, increased LVEDP, and the angina is the end point that happens where we try with the balance مع الميزان هذا to try to balance the oxygen demand and the oxygen supply. What's a typical angina? This is very important for your level, and it's very important because when you're in clinic, when you're on call overnight and you call me for a patient you saw, you have to commit yourself to what you say. So typical angina has to meet these three criteria. If it didn't meet these three criteria, it met 2, it's atypical angina. And if it meets only 1 or none, then it's non-anginal or cardiac chest pain. Why it is very important? Once I know you and you describe it to me by the phone, the patient has typical angina. I know you ask this question. I know what's the meaning of typical angina. So typical angina, it's easy. Constricting chest comfort. زي الفيل جالس على صدري. هذا وصف أغلب المرضى. Comes with exertion, سواء emotional أو physical, and relieved by rest or nitrate. الثلاثة هذه لازم تيجي عشان مضلع الأنجينا to be called typical happen. Without it, you can't call it a typical angina. Okay? I hope it's very clear. Atypical, if you lost one, يقول لك يجي مع الexertion ويخف مع الرest. However, it's not constricting. أحسه static. That's atypical angina. Why we want to classify? Because typical angina, ممكن على طول I'll move him directly up the ladder of investigation and just do an angiogram for this patient because it's typical story, convincing evidence, then I'll take him immediately to know what's the problem by occlusion. لكن إذا كان atypical or non-angina, then you can just take a step back and start doing some investigative work to dissect the patient and know which direction the patient has. Does he truly have a CAD presenting atypically or truly have nothing, an esophagus that is causing problem, a muscle, muscle cramp in the chest wall. We have this skeleton, the cage, the rib cage has cartilage, has joints. Any abnormality in these can cause pain that can mimic an angina and lead to over-investigation sometimes. Okay, you have to know also Canadian Cardiovascular Society. This is very important because whenever there is a patient with angina, بعد ما تذكر لي, if the patient has angina, you have to know what class he is. He's a class 1, meaning that he does it only with severe exertion. So that's the class we want to aim for all our patients to be at. Class 2 with moderate exertion, class 3 with mild exertion. There is an example to what activity is relevant to. And when the patient has the angina at rest, then he upgrades himself to class 4. So it's easy to remember that class 1 is with severe exertion, class 4 is at rest, class 2 to 3 is in between. So sometimes I even use it as 3 classes, class 1, class 4, and class 2 to 3. Then there is an overlap sometimes between the activity the patient has. Okay? And this is a table that shows you the percentages of having a typical chest pain, how it impacts the predictability of having a true CAD. And non-anginal chest pain, خاصة مع الage group, the more older you get, the higher percentages that you have significant CAD. Look at the left side of the table. If the patient comes to you with a non-anginal chest pain, non-cardiac chest pain, وعمره 40 إلى 50, can you see that only 13% truly have a disease? That's why we try to neglect these symptoms and we'll try to investigate to increase that sensitivity. أنا دائما أشبهها للمرضى إنه it's like a glass, يعني نظارة see through glass. النظارة هذه لو لبستها وكان في الصالة 100 مريض، بالنظارة هذه حأكتشف فقط 78%. يعني في 20 or 13% I will not see لأنه sensitivity حقتي is not high enough. Okay? So you see how it's transformed from non-anginal to atypical, it's increasing the rate. And once you have a typical chest pain and above 60, you have 90, and a male, you have 94% truly you have a CAD. هذول المرضى اللي I take them to the cath, I don't waste my time by stress test, echo والكلام هذا. Immediately take them to the cath to try, because I know by 95% I'm right that you have CAD. So that's why important the history to differentiate typical, atypical, and non-cardiac chest pain. It's the same, but more updated one from the European guideline. It's called the pretest probability, which will help you impact your judgment. Okay. This is something in the statistic. I don't think it's the avenue for it, but once you know your pretest probability and you know the sensitivity of your test, you would know the post-test probability by aligning the pretest مع likelihood ratio, and then you will get a projection into the post-test probability or how much truly the patient has the disease. This is something you'll take in statistic. Okay. Let's see that this patient have young yet have typical symptoms. So this would justify having non-invasive testing to stratify this patient. And on that basis, you can take him to the next step on the ladder of investigation. So the aim is usually to diagnose in the majority of patients for the non-invasive stratification, because that's what they will come to you. They are seeking a diagnosis. They never labeled as CAD, but if the patient has a CAD, you know he had a heart attack 2 years ago and he got stent, and then you want to prognosticate, to know that your treatment is working and the patient is doing well. Then you can use also the non-invasive testing to classify your patient. Here's the test that is usually we start at. It's an exercise stress test. Not all patients can exercise because with some people have knee problems, some are amputees, some they can't just because of their body habitus, they can't run. If they can't, then you can upgrade it to a nuclear test. It's called MIBI, perfusion test, or a dobutamine echo. And the more we go down, the better the test it is. The MIBI has, I think, 80% sensitivity. The dobutamine has 90 to 95, depending on who reads it. It can be a very good test to include and exclude the patient from a diagnosis. Okay? You don't have to really discriminate in between this. When you do cardiology or internal medicine, then you have to know if the patient has left bundle, can you do a stress test? No, you can't do a regular stress test because the left bundle will hide any ischemic changes. So immediately, if the patient has a left bundle, then you do nuclear test or you do the dobutamine echo to identify if the patient has ischemia. And here's the table showing you that the sensitivity of these tests, how good are they in sensitive, meaning snout, so ruling out the disease, and specific is spin, so ruling in the disease. This is again statistic. It can be helpful to know when you order the test, to know these numbers. And you just rough number. The worst is a stress test. The best is a CT angio. A dobutamine echo is higher actually than 81, specifically and stress echo, specifically in a good center where they do a lot of stress echo. It can be helpful, and it can be even higher than that. It reached 90 in some centers. Okay, so this is again the same, different modalities. And what is a significant test? This is again, it's too advanced. It's just to know that these tests are used to identify and diagnose and prognosticate patients. How would you manage a patient with CAD? The majority is to treat and then a quality of life وفي quantity of life. And quality of life is the most important thing because there is rarely an efficient way to reduce improve. Sorry, it's important when you're treating a stable CAD patient to care about the quality of life, because the quality of life is the most disabling symptoms the patient might have from angina. And once the patient have a diagnosis, خلاص احنا وصلنا الdiagnosis using the previous slides. Now we want to treat this patient to make his life better. His CCS class was 4. You want to make it 1 because he can't go exercise, he can't take a walk with his family, and you want to improve his quality of life by giving him medication. The usual startup medication in this situation, what we call it cardioprotective treatment, is aspirin, an ACE inhibitor, and statin. These patients, usually, even if they are not hypertensive, you can start them in a small dose of ACE inhibitor once you have a confirmed diagnosis of CAD. Of course, you have to treat the risk factors. If the patient is diabetic, tighter control of diabetes. If the patient is dyslipidemic, tighter control of dyslipidemia. If the patient is sedentary, you ask him to exercise regularly once his symptoms is resolved, to aim for at least 30 minutes heavy walk, not regular walk, 3 times a week. Then after you finish giving the cardioprotective treatments, the one mentioned above, then you can start giving the patient the anti-anginal treatment, starting with the beta blocker, TNT, which is nitrate. That helps and aid to the already started medication and helps in the balance, the mizan logarithmia. It helps increase the oxygen supply. At the same time, some of them decrease the oxygen demand. And then you can even, if the patient is still asymptomatic, despite the treatment you provided, then you can consider revascularization as an option, because revascularization in CAD patient, in stable and chronic coronary syndrome, is not the first choice because it's invasive, and the medication does as good as, and sometimes even better than revascularization. So that's why we keep and reserve revascularization for patients with persistent symptoms, despite the medication that you prescribed appropriately. The patient is taking that medication and he's not improving, revascularized him, and he's still symptomatic, then you have to move up to the ladder into something advanced called chronic angina and refractory angina, where we can use ivabradine, ranolazine. It's a specialized medication, limited access to it, but it can help these patients relieve angina. Okay. Again, the steps, you start by the cardioprotective agents, and then you start adding by the medication, the beta blocker, calcium channel blockers, until you exhaust everything. Then you can move up to the ladder of ivabradine and nicorandil, ranolazine, trimetazidine. All of these medications are highly specialized. We'll never probably prescribe it unless even you're treating chronic angina patients. Here's the studies and the proof that this medication works. As we mentioned, all the patients should have aspirin, ACE. And here's the name of the studies that did improve survival in patients with CAD. Then modifying the risk factor, as we mentioned, balanced diet, you target a good body weight and a good exercise program, and smoking cessation, and control diabetes better. This is variety of beta blockers you can use. You just need to know few or one of each class. If you're treating a hypertension, you can even give labetalol or carvedilol because it have alpha blockade effect, which will lead to a better or vasodilatory effect, reducing blood pressure if the patient is hypertensive. There is wide variety. I think at your level, it's not important to know the subclasses, but there is advantages and disadvantages to some of these patients. As you can see, no ISA or with ISA, it depends on the case. You want sometimes ISA. ISA is intrinsic sympathetic activity, which means that this medication that has ISA, it will increase the sympathetic tone. It sounds counterintuitive, but sometimes you want to achieve that. If the patient is truly very hypotensive and yet you want to give beta blocker, having that can be beneficial. Okay? And here's again, the nitrate also can be tried to try to reach a nice balance between the demand and supply. Calcium channel blockers, we have mainly nifedipine and amlodipine, which is antihypertensive. It can help increase the coronary vasodilatation and reduce also the high blood pressure, which will reduce the tension and reduce the oxygen demand. Ivabradine and ranolazine is not much of an important at this stage. You just know that there are other drugs. If you want to know more, you can read, but I don't think you will be asked about them. And this is an advanced also treatment for end-stage chronic angina patients. This is the machine. It's called enhanced external counterpulsation, where it pumps external. It's like a massage machine. It improves the retrograde flow into the aorta and coronaries, which will lead into improved coronary perfusion and reducing angina in this fashion. And this is another method. If you really reach the end stage with this patient, you treat them with everything available, and it didn't help. So aside from the ladder, الميزان اللي ذكرناه, oxygen demand and oxygen supply, what we can do is mask the heart, نخلي الheart blind from the pain. So we put a modulator in the spinal cord to send signal to the neurons supplying the spinal cord to the chest, and that will lead to يعني كأنك أنت بتعمل قلب إنه ما يحس, يعني numbing the heart from having the chest pain. Just 1 second, guys. هلا. بارك الله فيك, شكرا. طيب معلش we had interruption. So going back, revascularization again, it's not the first treatment of choice for stable CAD patients. However, for certain population, it might help prognosis or the quantity of life, and it will definitely improve the quality of life of certain patients when the medication does not work. And here's an indication to whom you should offer treatment. Usually it is a left main that is significant, triple vessel disease with reduced LV function, or even a second two vessel disease with a reduced approximal LAD. These high-risk anatomy would benefit from revascularization on the get-go with initiating treatment. And then comes which is better, CABG versus PCI. For certain population, mainly the diabetic, low EF, multi-vessel disease, high syntax score, surgery is better. The rest, surgery is as good as PCI. So PCI takes a big chunk of these patients because it's a low-risk procedure and yet have the same result. However, patient diabetic, patient have low EF, patient have multi-vessel disease with high syntax score. High syntax score, it's a score that we use when we look at the angiogram, and it will show us the degree of complexity of the disease. These patients benefit from surgery. The high syntax score, higher than 32, okay? Again, it's the same thing, and I think it's important to know, it could be an MCQ question that will ask you which of these subgroup would benefit from surgery being a best option than PCI. طبعا all except مثلا, diabetic, they will benefit, low EF, they will benefit, multi-vessel disease, they will benefit, high syntax score, they will benefit, meaning that CABG is better than PCI. Then خلصنا الحين الchronic. Anyone have a questions about the chronic coronary syndrome or the stable CAD, stable ischemic heart disease, before we go into the acute? Acute is easy and quicker. هاي شباب, تفضل اللي عنده سؤال يسأل before we go into the acute. ما في سؤال؟ طيب, go ahead. تقدر إذا مسموح لك تفتح المايك افتحه, ask the question and we'll answer it. Or you can type it if it's not allowed due to system. تفضل.
شكرا يا دكتور. دكتور, سؤال المانجمنت للكرونيك كذا, بس نبغى البريفنج عن المانجمنت اذا ممكن.
المانجمنت الكارديو بروتكتيف في السمر اللي في التيبل هذه. هذه cardioprotective treatment aspirin كل المرضى اللي يجوك with stable diagnosed stable احنا خلصنا من diagnosis stable CED تبداهم على aspirin slow dose ACE inhibitor even if they're not hypertensive but a small dose that will not lower their blood pressure a statin even if their cholesterol. Once you have a stable CED you want to aim a cholesterol less than 2. But most of us have a cholesterol between 2 and 2.5, so statin is still yet indicated. بعدين تبدأوا على beta blocker النيتريت puffs as a needed medication. إذا البيتا blocker didn't resolve the pain, then you go down the ladder, give long-acting, you can give calcium channel blocker. If it didn't help, you can add even nitrate, الcombo. ما نفع ايش تسوي؟ then you move up the ladder. Revascularization as an option. Medical treatment is exhausted, so revascularization can be an option. Okay, the aim is to reach the triple therapy: beta blocker, calcium channel blocker, and nitrate. Okay, واضحة ولا كيف؟ Very good. If anyone has any questions or anything is not clear, please let me know. لأنه we're almost done from the first lecture. راح ناخذ بريك ممكن 10 دقائق ونبدأ الليكتشر الثاني. طيب. Myocardial infarction, acute coronary syndrome. Acute coronary syndrome زي ما ذكرت لكم it can be sub-classified.
حتى رشحت واحد ثاني من الليفل الوحيد اللي فيه اثنين لو وصلت كل خط ما بتشوف اثنين مرشح للحد بس النهاية اختارنا المقابلات انك انت تبغى تخلص من الموضوع
عادي بس لو عندك سؤال ولا ميوت yourself. طيب I'll mute everyone. طيب ممتاز يلا. Going to the acute coronary syndrome, you remember this diagram اللي شرحت لكم فيه the spectrum of atherosclerosis that can happen. This is the process that happens at birth and then goes up into becoming a stenosis. بس احنا بنتكلم عن different animal. It's the ACS, acute coronary syndrome. Even at 20% lesion, patient is angry, patient is stressed, having an infection, corona, having any important stressful event that happens. This plaque rupture, opens, and when it's exposed to the blood, it gets thrombus forming like this, but it happens at this stage. So it can happen to the 20% stenosis, can happen to the 30% stenosis, and definitely it can happen into 70% stenosis that we discussed if the patient has stable CED. But the acute coronary syndrome can happen at any time with any percentages of stenosis. حتى في theory at some point, they said that the majority of STEMIs are not the 90%, it's the 20-30% stenosis that can rupture because they have thinner cap and they rupture easily, causing, if it's a complete occlusion, a STEMI. If it's an incomplete occlusion, depending on the degree of occlusion, can be non-STEMI or unstable angina. The management, the definition, going back one step, for the definition, you have to, it's not that important to know, but there is a classification. There is a classification of, or they call it a types of MI. It's a classification of pathology rather than classification of like what caused it. So the majority that you should know of, that all the STEMI that comes to the emergency due to ruptured plaque, it's type 1. There is a fixed stenosis in this patient or a patient with a stable coronary syndrome or chronic coronary syndrome, and then you exert him due to anemia, he's bleeding, so he's tachycardic, has AFib. The supply, the demand increase and the supply decrease because he has a fixed stenosis. He leaks a troponin, and then this is type 2 MI. So MIs can be categorized due to the cause into type 1, type 2 we mentioned. If it's due to a cardiac arrest, patient has arrhythmia and then boom, he arrested, he causes ischemia and an MI, it's called type 3. Post PCI, if I stented a lesion and then I jailed the vessel and I caused an MI, I caused an MI by my intervention, it is classified at type 4A. And then we have for the stent thrombosis 4B, and 5 is post-surgery. It's just to categorize patient to A, know their cause of the MI. B, is used for research purposes to know what is the most common cause of MIs. Obviously, it is type 1, and the second is type 2. It is also at your level, I would advocate to know one of these risks. It's a risk score. We have TIMI score system or GRACE score system. For any patient with ACS, STEMI, be it or non-STEMI, it's good to تضيف بعد ما تديني diagnosis in your history. You say this patient diagnosed with non-STEMI, his STEMI score is this. It's a scoring system that tells you what's the patient risk of death, MI, and urgent revascularization within the next 14 days. Each takes a point. Age above 65, more than 3 coronary artery risk factors takes a point. Stenosis that is known to be more than 50% by an angiogram or a CT. Aspirin was taken for less than 7 days. 2 episodes of chest pain in the past 24 hours. Or in a duration of 24 hours. ST depression on an ECG of 0.5 millimeter at least. And a biomarker that is positive. Then you add up the point. If it's full, let's say the patient has every point, then it has 40% risk of death, MI, and urgent revascularization. And these patients are sick. This patient needs to be admitted. لكن إذا جاني مريض ما عندي troponin, he doesn't have any major risk factor, and he has only 0 or maybe 1 point, his risk is 4.7. So I can negotiate, yeah, I might not need to admit you, I'll give you medication, and then I'll see you in clinic. That's why we use scoring system, to help us prognosticate patient and to help us know which patient needs intervention now, which patient can wait. Especially if you're working at a busy hospital, you have to prioritize your patient. So the only 2 scores that I want you to know, forget about the GRACE. GRACE is complex. I just want you to know 2 scores. TIMI risk score and KILIP classification. If you know those 2, those are important, and those are the one that I would justify that your knowledge at your level should know it. So خلصنا من TIMI risk score, we have KILIP. KILIP class is exactly just to classify the patient degree of heart failure with his MI. It's coming with an MI and a cardiogenic shock, then he is class 4. The patient is only have crackles up to 50% of the lung fields, then it's class 3. Less than 50% with an S3, maybe an S3, then it's class 2. Class 1 is a dry patient or not in heart failure. Why it is also important? Because it can predict mortality. لما تقول لي إنه الpatient has a non-STEMI, TIMI score 2, and KILIP class 4, then this patient is sick and he needs an immediate intervention. حتى overnight, you call the interventional cardiologist to come and do the procedure. Majority or almost all of these patients should undergo invasive strategy rather than medical therapy for those compared to the previous one. طبعا تعطيهم المونة على قولتهم أيامها مونة, morphine, oxygen, nitrate, aspirin, monitor them, ECG, troponin, and then if the patient is having a high score, you immediately take him to the cath lab as early invasive strategy. If he has a low risk score, and he's an example, TIMI risk score 0.1, GRACE less than 109, risk of complication is high, comorbidities, then you would tell this patient, okay, I can maybe ask for investigation before I can take you to the cath lab and comment on that regard. So early revascularization for the majority of patients based on their risk score, KILIP and TIMI risk score. All patients should have a dual antiplatelet therapy. And this is something you should know. Aspirin for all patients, for life. Once you have a diagnosis of ACS, aspirin for life. Then you give a dual antiplatelet. The second antiplatelet you can choose المتوفر في السعودية ticagrelor and clopidogrel اللي هو البلافيكس والبريلنتا الأسماء التجارية. You load them with 600 unless the patient is above 75, then you give them 300. And this is important because dual antiplatelets helps the patient's initial treatment and reduces the risk of having a recurrent MI. So all these patients, give them aspirin, give them a second antiplatelet, be it clopidogrel or ticagrelor. Prasugrel, it's a very good drug, but it's not available for Saudi. GB23 inhibitor, it's in the old days they used to give it upfront as part of ACS, but now it's only in the cath lab. It's an antiplatelet that is very powerful, and you should limit the use of it only by cardiologists or interventional cardiologists in the cath lab. All patients also should heparin, سواء low molecular weight or unfractionated heparin, in addition to the aspirin and Plavix or aspirin and Brilinta. The most commonly used is heparin. If the patient kidney function is good, low molecular weight can be given safely, and it's actually superior to unfractionated heparin. Okay. As you can see, it's just a reiteration to everything. If you want to take the patient to the cath lab, don't give unfractionated heparin because it's not easily reversed compared to heparin. Give heparin because we give, our procedure is a heparinized procedure. When you look at the ECG for ACS patient, you have to know this anatomy. I think I'm going to give you a lecture about ECG. We're going to spend more time and detail in dissecting how would you identify an anterior MI, an inferior MI, a high lateral MI, or a low lateral MI. But this is a summary of, if you cut the heart into cross-section, this is what happens. The LED feeds the anterior wall, so when it's occluded, it's an anterior STEMI. The marginal and the circ gives the lateral wall, so when it's occluded, the green disappear. And there's an overlap between the right and the circ. So the right, when it's occluded, gives you inferior and sometimes lateral if it's a dominant one. We'll spend more time for the ECG lecture about differentiating that. Again, it's the same thing. Treatment of STEMI, it's a little bit different than non-STEMI. STEMI, because the time is muscle, you have to rapidly act and you have to treat this patient acutely because it can get worse without intervention. The intervention for STEMI patients is two, either PCI or thrombolysis. In my whole practice, I've never given thrombolytic until just now for the COVID area because of logistics والحظر. فصرنا ما نقدر ناخذ المرضى للبرايمري PCI, which is the best solution. We give them thrombolytics. For now, we've been giving thrombolytics a lot for these patients. But it's also a good alternative. إذا أنت شغال في منطقة طرفية ما فيها cath lab, giving thrombolytic can be beneficial. But it's very important to know that thrombolytic works best if the symptom is less than 3 hours and the PCI is impossible, or the PCI is more than 120 minutes. And here's the regimen. There is different thrombolytic available at different hospitals. PCI is superior, specifically in patients that cannot take thrombolytic. PCI readily available for less than 20 minutes, less than 120 minutes, and the patient is in cardiogenic shock. You can't give thrombolytic because he needs a definitive intervention, where thrombolytic helps just unblock the 100% to make it 70% by resolving, at least establishing flow, reducing the STEMI to non-STEMI status. The same applies, but you never give thrombolytics for non-STEMI. Non-STEMI, it's cath or medical treatment, and that's it. This is again repeating the same thing about what should you give for this patient as an adjunctive therapy, aspirin, Plavix, all. You give unfractionated heparin, and you give them also protective for their stomach because cytoprotective, because giving aspirin Plavix is asking for GI bleed. So you give them degree of cytoprotection by giving them proton pump inhibitor. All patients with MI should get a beta blocker if they're not in heart failure as part of the treatment. All patients also with STEMI, they should have ARB if their LV function less than 40. All patients should get statins, irrespective of their lipid level. And this is what I usually tell the patient before discharge. Smoking cessation if they're smokers. Try to manage the risk factor. If his diabetes is under control, try to control it. And send him to an endocrinologist to optimize his medication. Smoking cessation, control of the lipid with a target less than 2. Blood pressure control, if the patient is not diabetic, 140/90 is the target, below that. Diabetes, hemoglobin A1C less than 7, a BMI that is ideal with a waist less than 120 for male and 88 for female. Balanced diet with physical activity at moderate exercise. مو يقول أنا بمشي. المشي is not an exercise. It has to be moderate intensity, like rapid walking, 4 to 5 times a week. Influenza vaccine annually, because these patients with coronary artery disease are at higher risk of mortality from influenza, so you have to protect them. It's very common to have depression after an MI, so if the patient is reaching the clinical depression, then treatment is also beneficial. A sick leave I would give 2 weeks usually, but if the patient has LV function, maybe up to LV dysfunction, I might extend it to 1 month. Sexual activity can be restarted at 7 days. And I usually tell the patient if they're sexually active to take 1 flight of stairs. If they don't have angina, then they can resume sexual activity without restriction. It is very important that they shouldn't use Viagra or Cialis without consulting their doctor, because if the blood pressure is low, or if they're taking nitrate, taking Cialis or Viagra will cause severe low blood pressure, and then they go hypotensive, they might die from it. So they have to be careful with that regard. Okay? طبعا الترافل, there is restriction. A fresh MI cannot fly if they're hypoxemic, should not drive if there is LV dysfunction. So again, I've treated a lot of private drivers here في السعودية with low EF. أنا حتى لو بيدي أسحب الرخصة, because they are at risk of ventricular fibrillation, and you don't want a patient or اللي جنبك في السيارة يجي له ventricular fibrillation وأنت متراكب معاها أو بتسوق جنبه, because that's what will happen. These patients need to rest for a month to check their LV function to make sure that they don't develop VFib and die while driving. So driving restriction is important. احنا ما نطبقه في السعودية بشكل زي as it was before in other countries, but it should be strict. A driver or a person who drives should not drive if there is LV dysfunction after a STEMI, because it can cause harm to others. لأنه ما تبغى تكون في طريق الملك فهد فجأة واحد يدخل عليك لأنه he fibrillate while he's driving. This is not very important. It's a variant of angina. It's due to vasospasm. It happens for patients that are usually female, smoker. They have migraine, and they're mainly they have psychiatric issues. The treatment is tough, not easy. The diagnosis is even tougher. But once you reach a diagnosis by ergonovine provoking test, you can label the patient as vasospastic angina, and it's hard to treat. Calcium channel blockers and vasodilators are the only treatment available, and the others are still experimental. Okay. I think that's it for the lecture. Let's take a break for 10 minutes, then we'll start the valve. But before that, anyone has a question? اللي عنده سؤال يسأل. حياكم الله. خلاص ناخذ بريك. وإن شاء الله الأمور تتحسن ويصير we'll see you face to face زي السنة الماضية، كانت أفضل الإكسبيرينس. خلاص 10 minutes at 2:40 نبدأ المحاضرة. أوكي، أنا هخلي الكمبيوتر مفتوح و if anyone has a question they can come.